Seif ShekalagheSeif from Ifakara Health Institute in Tanzania, where all this is going to go to the field.
Hello, I'm Seif ShekalagheSeif from Ifakara Health Institute. My background, I'm a clinician, so my talk will not be on developing assays or discovering drugs, but rather is on now testing and evaluating the drugs after this guy have discovered, and then they'll bring to us to test. My talk also is a little bit difficult, having heard yesterday the debate on Primaquine from Professor Nick White and Kevin. I don't know, most of the things that I'll bring to you will be a lot of questions to you than the questions to me. So it will be more of the discussions and trying to ask you the questions rather than asking me. But you are welcome. If you have any question, then I'm happy to take it, or rather bring it back to you. So way back in 2007, when malaria was significantly decreasing, and then malaria elimination agenda was back, and then we tried to test a single dose of a Primaquine. By that time was 0.75. In addition to the sulfadoxine pyrimethamine in Tanzania, by that time was the first line treatment to see if addition of this single dose could clear gametocyte and interrupt transmission. The design of the study was that we had two arms. One arm we have given sulfadoxine pyrimethamine and artesunate, and another one we gave sulfadoxine pyrimethamine, artesunate, and Primaquine. In both arms, Primaquine was given on the last day, on the third day. And then, as you can see here, we had 53 subjects in each arm, and we had one loss of follow-up in each of the arm. And the outcome of this study was mainly to look at the efficacy in clearing the gametocyte, the prevalence both by microscopy and also by QT NASBA, but also on the safety, looking how does the Primaquine does to the blood. So as you can see, these graphs here. The first graph here, this was the efficacy by microscopy, of which you can see the line, the dashed line, this is the one that was true, that they receive sulfadoxine pyrimethamine, artesunate, and the Primaquine, and the other one received sulfadoxine pyrimethamine and the artesunate. And if you try to evaluate the efficacy by microscope, you see there's completely, you can say that the gametocytes were cleared completely. But you can see on day 14 the gametocyte reappeared. But if you evaluate that by QT NASBA, you can see, in fact, what the picture you are seeing here is completely different. That there was a substantial submicroscopic gametocytemia that still were persisting, and with the same picture that on day 14 they reappeared. And if you look now on the safety, again, the days of treatment relative to the hemoglobin, on day 7 there was a decrease. In fact, there was some of the subjects who they dropped up to 6 hemoglobin gram per deciliter. Remember, by this time, this single dose was given and was recommended not to test for G6PD prior to treatment. So all these subjects were given without testing, and enrollment HB by that time was equal or above to 80 milligram per deciliter. So this was the paper finally that we published for the work that I was just describing, and that showed that Primaquine clears submicroscopic Plasmodium falciparum gametocyte that persists after treatment with the sulfadoxine pyrimethamine and artesunate. And the same regimen that also we gave it in mass drug administration. And this paper, what we found is that hemolysis after single dose of primaquine by that time is 0.75 milligram co-administered with artemisinin is not restricted only to glucose 6-phosphate dehydrogenase deficiency. But in this case, remember that we gave in more than 5,000 people. So the HB by that time you could give people have 7 because we did not check HB. We only gave, that was way back 2008. So having shown you that there are some questions that we have come up with based on the two studies, that 0.75 is efficacious in clearing gametocyte. However, the remaining gametocyte is circulated at a very low density. As we have seen on day 14, the gametocyte reappeared. So we had your question, are these submicroscopic gametocyte infectious? Because these people are in the population, they are asymptomatic, so we don't know. The second question was that the gametocyte that reoccurred on day 14, what is the reason? Is it because by that time we gave sulfadexin pyrimethamine and artesunate? We didn't have more efficacious ACT? Or was it because the primaquine were given on the last day, on the third day? Maybe if it was given on day 0, this reappearing, we could have not seen it. The transient significant decrease in hemoglobin, was it because some of the subject there is, we did not test for G6PD, we are G6PD deficient? But also, how about the HB at enrollment? Because it was 7 or 8 grams per deciliter. So these were the questions that we had. And we said we need to investigate this. So to investigate this, then we had designed another study to investigate the optimal time of administering primaquine with effective ACT to interrupt transmission. And this was the design. We have learned from previous study that we needed to screen for G6PD. So we excluded all subjects who are G6PD positive deficient. And also we have set our HB that we enrolled all the subjects who had HB below, sorry, there's a typo here, 8, below 8, we excluded them. So those who were G6PD, normal G6PD, were randomized either to receive artemethyl-mefantrin and primaquine on day 0. And then all those that were randomized to have only coartem, artemethyl-mefantrin, and the third arm that received artemethyl-mefantrin primaquine but was given on the last day, just try to answer the question that probably giving on day 0 or day 2, which one is better. So we enrolled 3 up to 17 years old children, and who was supposed to have a normal G6PD, and HB should be equal or above to 9 grams per deciliter. So we gave either standard dose of coartem, as I have said, or give a 0.75 milligram, but they are given once we have tested, as I've already said, just to save time. And our primary outcome was efficacy, gametocyte prevalence, and density by microscope and QT NASPA on day 14, which will be compared between primaquine treatment 2 and 3. That means the one we are given primaquine on day 0 and the one we are giving primaquine on the last day. The secondary outcome is comparison of hemoglobin from day 0 up to day 14 after the start of treatment between the 2 primaquine arms. This is the study is ongoing up to now, as I'm telling you, and this is the recruitment status so far. So we had 1782 subjects that attended the facility, and then we are recruiting from site A and site B. And from this site, as you can see, there were 49 eligible subjects here, and also 52 subjects in this site here. So in total, we enrolled 105. The data is more now. We have enrolled more, 120 because the study is going on. And then they were randomized into either ALU alone, that were 35, and then 34, and 34 in another arm. So these are the preliminary results. They are not final because the study is going on. So this is just the profile of the subject, as you can see. In both arms, these are the number that were enrolled in each of the arms. This is the age category. And you can see here the geometric hemoglobin mean by HemoQ. These are the values, and also we also try to do by full hemogram. We did not only depend on HemoQ, but the HemoQ was the one that we are basing on enrolling the subject. This one was done retrospectively later, but we just wanted to compare. The treatment outcome, preliminary, as you can see, doing pretty much very well, as you expect. So you can see here on the ALU treatment, parasitic clearance on day 3 and day 4. But you can see here in Primaquine that was given on the last day, there's only one subject who is not cleared. In terms of the safety as hemoglobin now, you see here that these are the follow-up visit, and this is the mean hemoglobin. As you can see, this is the arm that was given ALU, Primaquine, and day 0, compared to the one that we give ALU, Primaquine on day 2, the last day. So you can see that there is still hemolysis, which is associated with the Primaquine. And these are the participants that reported total E. We did not yet go into individual data, so this is really pulled in the all group. So far you can see most of the reported adverse events were the transient hemoglobin, which we have seen from the lab. And then so far there is no any serious adverse event reported. So the trial, we are still recruiting, and we are facing some of the challenges. Since we started the enrollment, it's 1.5 years now. The target is to recruit 250 subjects, and so far we have recruited 120. We are due to recruit 130. So the recruitment is really extremely slow. Some of the reason we are thinking is because these subjects are coming with malaria. So because we are excluding subjects with the hemoglobin of 80 grams per deciliter, and most of them who are coming with malaria, they have anemia. This is one of the reasons. But the other big reason also is that we are working at the area where it's low transmission. So there is a really low malaria cases. So this is what I think the preliminary conclusion and probably points for discussion, that 0.75 milligram was single dose of Primaquine given at day 0 and day 2 is still efficacious and may be safe when administered at HB above 9 milligram per deciliter in G6PD normal subject. A Primaquine given at day 0 is likely to be more associated with the hemolysis than the one that is given on day 2. The efficacy result on day 2 and by PCR is still pending because we are waiting to complete the whole study, because I need to send the sample to the Netherlands for that. So further analysis of HB result at individual level will be very important. So then we are able to see these ones who have come down to 7. You can see how many, because this is really the whole group. So here some of the questions that I think are for discussion, that the role of 0.75 milligram Primaquine that has been used and is shown to be efficacious in clearing gametocyte. It does harm, but it is efficacious. But if it's given under controlled condition, the hemolysis effect is reduced. But probably this is not intended for the use because the primaquine is used for the mass treatment without, not under control, not testing for HB. So it may not be ideal. So is it worth further evaluating this treatment as now this trial we are doing? Because when we designed this study, the newly recommended dose of 0.25 by that time wasn't there. So it has just come while this trial was already designed and is going on. The recommended dose probably is safe, but does it have intended efficacy that we are thinking? Considering the fact that when we use 0.75 milligram, gametocyte reappeared on day 14. How about this small dose? So this is a question that, is it worth still looking for this and maybe think maybe this could be used on other purposes, for example, not into the mass treatment, into mass drug administration, but probably this dose, if is given under control, and that could be given people who have malaria, have just completed the other treatment, and then they are HBSI, they don't have, they are normal G6PD, you can give them. Just as an example, the bed net that is used, not everybody, the member in the family is using bed net, but it has an effect to decrease malaria cases. So just as an example. How about other doses that has already been found to be efficacious, like 0.4 milligram? Why not to be recommended rather than the smallest dose? Maybe there are still studies needs to be done on that. In terms, as I have shown, that there's a extremely delaying in recruitment because of low malaria cases, as malaria cases now are decreasing. Is there a need in speeding up evaluation of the primaquine doses that are being recommended? Because if we rely on natural malaria transmission and infection, this will take long, like the trial that I'm doing now. What is the role of using controlled human infection in evaluation of these primaquine doses? Maybe yes, but are these results can be applied or generalized in a natural settings? That can we use this result and then now say that, well, this dose it can be used, or are there limitations? So that's it, and very short presentations, but I think there are some questions that we still need to answer. Thank you. I would like to acknowledge my collaborator. First to thank you, study participant and the study team, and then collaborator, Chris Directly, Ton Borzima, Hugh, Salim Abdullah, and Franklin Moshe from KCMC. This study is funded by Wellcome Trust through Thrive project. Thank you.
I have a few follow-up questions on this. What percentage of the population did you have to exclude when you focused on G6PD normal? So what percentage of individuals had to be excluded because they were G6PD deficient?
In this trial that
in that study, yeah.
Well, I don't remember, but the area that I'm doing this study is in general population. The data that we have way back 2005 is 7%.
Okay. And then with the hemolysis, because obviously that's quite concerning, are you looking at like the CYP2D? Are you looking for, CYP markers that might explain hemolysis in that subset of individuals?
No. Right. So here for me, because we are recruiting at the field, we just use HemoQ is 9, and then we recruit, but we are taking blood and send to the lab to do full hemogram.
And then in terms of its impact on mature gametocytes, I know James McCarthy has this very nice qRT-PCR method to look at reduction of mature gametocytes based on expression of mRNAs from late gametocyte genes. Are you storing samples so that you can actually look in vivo for reduction of mature gametocytes?
Yeah, so I don't know what to be the method, but I'm using the RNA protect to store the sample, and then I'm putting -8. That's the so we have the sample.
Yeah, because I don't know. I'm not sure if you mentioned the Netherlands. I'm not sure if they're doing it, but McCarthy's method seems very quantitative and sensitive.
Tony is a collaborator in this study, so we intended to go to do the analysis at the Professor Robert Sauer lab, because also all previous trials that I presented, the PCR was done in NIMEC.
I have again a question on safety. You said that you had no severe adverse events, but how was that defined for anemia and hemolysis? What were the threshold for SAEs?
The definition was SAE, then it's any serious condition that may sustain life-threatening or may result to hospitalization. Yeah, so in the current that I have presented, we did not see any subject presenting those.
But how deep would be an anemia that you would consider life-threatening? It's 7 grams per DL? How much is it?
I don't know, maybe there are some clinicians. We are, for example, in one study which we did, there was a child who had 6 milligram per deciliter and was just walking is fine. So some patients in the hospital have 5 milligram per deciliter are transfused. Okay. So it depends if at that point and that hemoglobin they are having, if it is life-threatening. And the ones that we have seen here, like 6, we know the transient is coming. We are just keeping, close observation.
Maybe a suggestion when you express the results of this kind of studies, as soon as we come to safety, mean or median values are interesting, but this is not enough. We want to know what proportion below a couple of thresholds that are meaningful. And it's crucial to know whether there was 1 or 2% below 7 grams or below 5 grams, because it's a complementary vision of safety that's crucial. And because of the world discussion of yesterday, we're not sure of any individual benefit, and so we need to be very sure about safety.
Yeah, so as I have said, we have this data, and the idea is to show really like how much is the decrease and how many have gone below a certain threshold.
Thank you.
Thank you, sir. York.
With the subset, are you doing membrane feeding or direct feeding in the study, or subset of this?
Yes. So this study also, our plan was to do membrane feeding. And for the remaining 130 subjects, the plan is to do membrane feeding, but then is to do membrane feeding from those who are from 12 years up to 18 years, and not to children. It's still challenging, as when we started this trial, recruitment, we are hiring on the recruitment, and some of them you are asking them to consent for membrane feeding, and then they are not ready, so that's another challenge. Okay, thank you.
Thank you, Seif. Very few words to close the session, and thanks to the nice transition, thanks to Jorg talking about somehow ex vivo type of analysis with SMFA, with blood on patients. I will just very quickly go back to my last slide, which is this one, to show you that we have covered, thanks to the nice speaks and talked today, we have covered a lot of activities from early gametocytes, late-stage gametocytes, gametogenesis, and SMFA, and also clinical aspects, all of them targeting infectiousness. There are also some challenging issues, and probably you have seen, some of you have seen the nice speech which was given by Andrew Blackborough on the development of a mouse-to-mouse transmission model. to complete the full presentation here. So I would like, first of all, to close the session by thanking very warmly all the speakers of today. Big applause. I would like to thank my distinguished co-chair for the help. Thank you very much. And last but not least, all of you for resisting until this late hour. So thanks very much, and hope to see you soon. Thanks.